So I'm just going back again about some points that Caroline has already illustrated quite well. But these are really the main features of a patient that is in puberty. We'll go back to this slide again and again. So you need several points: the Tanner stages, which we have already seen, the growth, because of this pubertal growth peak, the bone age, laboratory results, and imaging studies. Thank you. So if we go back to the pubertal stage, so the Tanner stages, again, 1969. These are the Tanner stages of a girl. You can see there the M2 or B2, depending on mammary or breast, anyway. So it's a small bud. It can be painful. It can be unilateral and becomes then bilateral. No need to do an ultrasound. The simple palpation is enough to make the diagnosis. And as you can see with the arrow there, it takes 2 to 2.5 years before this first stage of the breast bud and then the first menstrual bleeding, which is called the menarche, usually. So the normal age, as Caroline has already said, for M2, the mean, again, is 10.5 years, but as we have seen, there is a wide variation of age of onset. For the boys, so for the boys, it's the testicular volume. Now, for the testicular volume, you better use what is called an orchidometer, which, of course, not every doctor has in his consultation office. But basically, that's why I put an image of an olive there, because actually the first stage of the first testicular volume, for me, it looks like an olive, sorry. A big olive, let's say. But then, yeah, once you see it's a big olive, then something is happening. It's a bit too big for a child, right? So it's the beginning of puberty, really. Now, of course, there are small and big olives, but then, you know, that's for me, yeah. And again, in boys, it will take around 4 years for the puberty to develop. What about the growth? So puberty is really characterized by the growth spurt, which is under the effect of the sex steroids. And the growth spurt is really this peak of pubertal, of growth velocity. So the chart there on the right is a growth velocity chart. So the number of centimeters per year increases during puberty. Now, of course, you need to measure the patient, and you also better have a growth curve. If you don't have a growth curve, there are many, many tools, but including online tools really ready, easily to get, to try to have at least 2 or 3 points on, of course, to have a growth curve. Along with the peak velocity, you also have a bone maturation, of course, because when puberty starts, it means that your growth will accelerate, but you also will arrive at a certain stage to the end of growth. So you mature your bone age, right? So there on the right, you have an X-ray of the hand. No need to do other X-rays, because I know in some places do elbow X-rays and everything. So a left hand is really enough to do a bone age, and you have atlas or apps. Though, as Caroline has told you, the actual peak velocity, so the actual number of centimeters a child will grow in puberty depends on the age of puberty. So as you can see there, when puberty starts earlier, actually the child will grow more. I mean, he'll grow more centimeters during puberty. Whereas late bloomers, so the children that have later puberty, they grow less. Of course, they have grown more before starting puberty, but then during puberty, the pubertal peak growth velocity is less. So that's one of the reasons why actually puberty, if it's not very extremely early, it doesn't, as Caroline has shown you the example, it actually doesn't impede your growth, and you usually reach a reasonable height. Because most often the patients are actually coming very anxious about the final height of their child. So that's just to illustrate to you what a bone age is. Actually, the bone age is actually the visualization of the growth plate. So this is the growth plate. You have these chondrocytes. They need to proliferate. So they proliferate in their matrix, and then at a certain stage they calcify. And so the actual bone age, you can see there a 10-year-old boy and then a 17-year-old, and you can clearly see that what you can see, the clear spaces there are actually, it's actually a visualization really of the growth plate. And it's a measurement of the potential growth, of course, of the growth that remains. Because needless to say, if you have a bone age of 17 years, it means you have no more growth plate, so you will not grow anymore. You have your final adult height. Whereas if you have a 10-year-old bone age, it means you still have some growth plate there and everywhere else, and you will still grow quite a lot. Yeah, so that's again the concept of the growth plate senescence. So you have a certain amount of chondrocytes that can multiply, and that's probably since birth, and then you end up, you will lose them over childhood. You have an ultimate peak during puberty, then you end up at the end of growth, you have no more chondrocytes that can multiply, proliferate to produce more bone and more growth. What were the laboratory results? So again, so if we go back to the basics, we have, if I see, let's take the example of a girl, if I see a breast birth and I have a good growth curve here, and you can see there is some growth acceleration, you have an advanced bone maturation, so here it means we have sex steroids around. Now the question is, where do they come from, and what triggers this this presence of sex steroids? So if sex steroids are present, well, is it from the ovaries or is it an exogenous exposure? Of course, it's rare, but it can happen. I won't talk about that. I put lavender oil, estrogel, of course, other endocrine disrupting chemicals we don't know yet. And if the sex steroids are from the ovaries, is it driven by the pituitary gland or is it an autonomous ovarian activity? So there the lab will really help us. So if I take the example of sex steroids presence from the ovaries and driven by the pituitary gland, this is what we call central puberty. And what characterizes central puberty from a laboratory point of view is really the LH response. So you can see there in yellow, these are boys, these are girls. This is Tanner 1, Tanner 2, Tanner 3. And you can easily see that when you have no puberty, so Tanner 1, the LH is really stays low, even though it's a GnRH test, so you have 0, 30, 60 minutes, usually finishes after an hour. And you have no response in LH. This is a childhood-like test. This child is not in puberty. You can see here when puberty starts, you have LH search. So you do a GnRH test and you have this LH which peaks both in boys and girls. So you can see it's really LH response which gives you the clue whether the pituitary is activated and is actually responsible for this sex steroid production by the gonads. So if you have already basal LH which is elevated, you don't need to do a GnRH test. But usually at the beginning of puberty, when you are in doubt about the fact that it's central or not, you better do a GnRH test. It only lasts an hour. It can be done whenever during the day, and it gives you a good idea about the activation of the pituitary gland. Now, if it's central, again, back to medical students, if you think it's the pituitary, then we need an imaging in case it's precocious, of course. If it's not precocious, you're not going to do an imaging for every child that is into puberty. But if it's precocious, or if you have another reason to, if there are other associated endocrine problems, of course, then you would do an imaging study, and the best imaging study for the pituitary is an MRI. So you would do an MRI of the pituitary region just to exclude organic causes of central puberty. Puberty can be just the physiological process, but it can also be triggered by an array of different local triggering factors. So what can be seen? You could have hypothalamic hamartoma, you could have glioma, you could have arachnoid cysts, You could have radiation, post-radiation puberty. So, and this is just a partial list, of course, of the possible findings you could find on this pituitary MRI you will ask for your patient. This is just an image of a nice pituitary hematoma, which is a benign lesion, but which classically triggers central precocious puberty. Yeah, this is another example. It's an MRI of a young guy. Actually, he had no precocious puberty because he was already 12 years old, but he had associated problems because he complained of diabetes insipidus. So that's the reason why we did the MRI. Otherwise, puberty-wise, we wouldn't have bothered doing an MRI because he was 12 years old. And he actually had a germ cell tumor. So he had chemotherapy and proton therapy. So that's just a summary of what we can find. So let's go from left to right. If you have puberty and your generate test shows that you have LH and FSH around, well, it's central puberty. Now, if it's precocious, you do the MRI, or but this is the most frequent scenario. In some cases, when you do the MRI, you could find this hematoma, for example. So this is still central puberty, but it's organic. So you have a lesion there on your MRI. So central puberty can be either idiopathic if the MRI is normal, or organic if the MRI is not normal, being an arachnoid cyst, or a hypothalamic hematoma, or a glioma, whatever. Now, we're over with the central puberty. If you do the generate test, you have no LH and FSH, it's suppressed. So then you have the impression it's coming from the ovaries. It's an autonomous ovarian or testicular. I always take the example of a girl. But, so an autonomous gonadal activity. Usually you have very elevated estradiol or testosterone, so your sex steroids are usually elevated. And also the dynamic of the pubertal development is also very rapid, usually. But then, again, the lab helps you, because if LH and FSH are very low, you have this evidence that it's gonadal in origin. You have different syndromes of autonomous gonadal activation. Here is the typical McCune-Albright cafe au lait spots. In a child, you could also have an ovarian cyst, very simply, or an ovarian tumor, of course. And here we are with the tumors again. So these are two examples of autonomous gonadal production, either tumors or rare diseases such as McCune-Albright or ovarian cysts. Then you have this child I showed you with his germ cell tumor producing HCG, and HCG mimics LH, stimulates the gonads, and this young chap, he had actually an HCG related puberty. Again, you have no LH and FSH, but you have testosterone, and it's only in males that HCG can produce testosterone activation, because girls need FSH. And what else? Yeah, this is in the case where sex steroids actually come from the adrenal glands. In this case, it's another family of sex steroids. It's not only testosterone and estradiol. It would have DHEA, androstenedione, and this would be an adrenal origin. Could be an adrenal tumor, adrenal block. And then, of course, you have these exogenous exposure. Exogenous exposure can be indirect. We have had some patients whose fathers were ointing themselves with testosterone gel, very high concentration, and steroids in gels. They are really remain very much in the environment, including the chairs, the curtains, the towels, and the bed sheets, etc. So yeah, there are some environmental sources which are really difficult to pinpoint. And one of them is lavender, actually, oil, which is very trendy those days because people like natural remedies, you know. And there are a few case reports, including a nice in vitro study really in the New England Journal of Medicine. So these are really good quality journals. And So again, lavender is probably estrogen, has an estrogenic effect. Now it's always difficult to document because how long has the child been exposed to, where, for which route, and for how long before he. So, but we have, for example, prepubertal males with gynecomastia, where the clinical impression is really, that's what's described in the New England paper, that there was a contribution of lavender. This is just to confirm that I like gardens and nature.